Thanks for inviting me, Sudhir and Naveen. It's always an honor to speak to the Indian audience. So I'm going to speak on something slightly controversial. It's about scaphoid plating and, why do we even need it, really? These are my conflicts of interest. So there's a reason why I'm putting this up, because I'm going to be speaking about the Medartis plate. But this is hopefully a balanced talk. I'll try and present our limited experience with this device. So do we really need a plate is the question, and I think that's a reasonable question to ask. We have casts, we have so many headless screws. The market is rife with all these different implants. And is there really a place for anything further? Because we know that the fracture will heal with a plaster or screws or even K-wires, as Dr. Patankar is going to talk to us later on about. And you'd be surprised to know that these plates have been around for some time. And in the 80s and 90s, there was a plate called as the Enders plate. And what it essentially did was that it prevented the escape of the bone graft from the fracture site. And I think they published a single paper in somewhere in 1992, I think it was in the European British Journal. But after Herbert's screw came out in 1984, because the ease with which you could put the Herbert screw in, even the non-cannulated version, I think the plating as a whole fell into a degree of disrepute. So if you look at the literature now, there are lots of case reports. There's one particular retrospective trial where they've published 32 fractures which have been treated by scaphoid plating, and they've been addressed in situations where there have been non-unions and also in acute fractures. Now, as far as Wrightington is concerned, my experiences with these type of scenarios, where you've got a bit of internal fixation in with cavitation, and you begin to wonder what's going on there with that distal pole, and we're going to struggle to fix that. Or if you have a non-union with a huge cavity like this, or one of my colleagues has done a few humpbacks where we put a plate down the front to correct the humpback deformity. The enthusiasts who have published, Greg Bain and company, they've done these in fractures which have a complicated anatomy. When you have these steep oblique fractures or comminuted fractures, they put dorsal plates as well. So when you look at the biomechanics of a single screw, we know that by definition, it will only offer very limited stability, and it's poor in rotation. And this depends whether you have a type 1 or a type 2 scaphoid. And this is work done by Fogg and his colleagues from Australia. You could use 2 screws, but that can be challenging. If you have a very narrow waist, this can be an issue. That's really where the plate comes in, that in theory, it can resist rotational displacement to a greater degree than you could with a single screw fixation. There's no question that if you were to use 2 properly placed screws, or even a screw and a stout K-wire, you could make up for the issues with rotation. So these are the theoretical biomechanical advantages that a volar plate would offer. So coming back to our plate, the plate which is marketed by Medartis, it's been around for some time now. It's made of titanium. It has 140 degrees tilt. It's connected with these 2 little metal bars, and you have 3 screws, one for the distal pole and one for the proximal pole. And one of the big advantages here is that when you screw this on, the 2 metal bars keep your graft in place. So it acts like a buttress. It doesn't really work as well, in my opinion, as any form of compression plate. And this is how it would lie on the scaphoid along the volar surface. So Greg Bain has published a paper, I think it was about 4 or 5 years ago, where he's applied a similar plate, but to the dorsum of the scaphoid. Now, I personally have no experience with this at all. Most of our experience, or nearly all our experience, is with the volar plate. So let's go to this very quickly. The approach that we use is the Garcia-Elias's approach. Volar across the FCR with the hockey stick extension. This is the exploration, as we can see. I tend to release the FCR quite distally in order to ensure that I can retract the FCR adequately on the ulnar side. Um, Amit showed us the anatomy beautifully, the radioscaphocapitate and the radioscaphoid ligaments. So this is a theoretically again uh, a ligament sparing procedure. So just to outline the two V-shaped flaps, you take these which are centered over the radioscaphocapitate ligament. Very often these ligaments are not this clearly visible. You can see the appearance of the proximal pole, the distal pole, and the gap. This is what the fracture would look like once it's fully exposed. So what becomes very clear immediately, I think, to all of you is that the exposure is very, very important in these cases. Because if you don't have adequate exposure, if you can't see the proximal pole, you can come unstuck very, very quickly. And the reason for that is to do with the impingement of the proximal part of the plate with the distal radius. So as you can see here, very clearly, that's the distal radius, and this is how the plate sits. So this particular case had a happy ending. We had a fracture which was waist towards the waist, a little bit distal. Once we were able to jack it out, we were able to get 3 good screws proximally and 3 good screws laterally, and that's what I would probably call a sort of a textbook situation. Doesn't always happen. This is the appearance of the fracture. And this particular injury healed within 4 weeks. 4 months. This was the other case which I showed you with a large cavitary defect, which we fixed with a plate. Again, plenty of real estate proximally, and that really is something that I look for when you use plating, because one of the problems that I've had, and I show you in a later case, is with impingement. You can mold the plate in a particular way, remember, because it's possible to then place it and contour it in such a way that the screws then move in this particular direction, and you just prevent that little bit of impingement which can occur. This is a case that I've done a couple of weeks ago, and you can see how easily you can get unstuck. In this particular case, I had to cut the proximal aspect of the plate because of repeated impingement. So we packed it up full of graft, stuck the plate in. One of the issues that I had was that the distal pole appeared to be splintering after we took the screw out. But unfortunately, because of the contour and the nature of the fracture, I wasn't able to place the plate distally enough. So as a result of that, I had to cut it, and you effectively end up with just 1 screw proximally, which in my opinion is, not great at all in terms of fixation. But God is great. We managed to get this to heal. But this is something that we do sometimes, where you have to contour it so it doesn't completely sit on the fracture, and you have to bend the plate in a way so that the screws can then move across. But this is a very important aspect, and very much on the learning side. I still believe, from my point of view, as far as my practice is concerned, with the average non-union, the average fracture that needs fixing, I would still use the headless compression screw as my method of choice. We'll publish our results when we do our first 50. We are looking at them prospectively. But there, we must have an open mind that there will be situations where an anatomical locking plate might be useful. And this would depend on the anatomy of the fracture, as well as the anatomy of the non-union and the presence or absence of huge bone defects. Thanks very much. Thank you.
Sudeep, unmute yourself.
Yeah, Naveen, any questions?
There is only one question for the plate.
Yeah.
If the plate does not compress,
Yeah.
how is it supposed to treat non-union in scaphoid? It's a
So,
buttress.
yeah, so I mean, I don't know what the rest of the panel think. When you have a situation where you effectively are taking down a significant chunk of bone away, so you have a non-union where there's a problem with the biology, you are trying to work on the biology, or you're trying to work on the vascularity to achieve union. So similar to how a K-wire works, or when you do large vascularized grafts, you have to fix the vascularized graft with the fixation, which can be only best described as tenuous. The plate works in a similar fashion. It works as a buttress. Biomechanically, all it does is it helps to hold the fracture molarly. I frankly don't believe in some of the lab work that has been done, where they have shown that it can actually help in providing compression across the fracture site. I think that is too optimistic. So I think it just serves a buttress function, and there's no going away from the fact that your preparation, like for all hand surgery, the preparation of your non-union and the quality of your graft is very important.
Okay. Before the next question, let me have an announcement. We started with 2849, then it was 4752, then 6285, and now it is highest at the peak at 6578. Thank
Okay.
you. Thank you all faculties for a great contribution. And now the next question again for Sumedh is,
Yeah.
most of the time these fracture non-unions are rotationally unstable. How do you stabilize them before you apply the plate?
So that's a very good question. So the order of, I apologize, I should have said this first. So I stick a K wire down the non-union. I ensure that the K wire has passed through both the poles and through the graft. You can virtually do this under vision, if you use an adequately shaped graft. And then what you essentially do is to ensure that you fix your distal part first, so that you make sure you're not sort of impinging, and then rearrange or position the plate over that proximal fixation. And the single K wire very often is more than enough for sorting out the rotational bit. The other thing that you do is to use this bolster, which we use, which I'm sure all of you use. You use a large bolster and you dorsiflex the wrist. So the minute you do that, you straighten up the scaphoid and effectively lock it in position. I find that quite useful.
Oh, so it's a controversial. So many questions are coming, pouring like anything. Was your decision to do of plating is pre-op decision or it's an intra-op decision? Anytime you change with the other matter and intra-op, you decided to go for plating.
So we've got a thing called Montgomery now in the UK, where essentially everything and absolutely everything, things that have taken me absolutely years to understand, I have to explain to my patient in a period of 30 minutes. So we have to go over the whole plethora, the whole range of options. So if I'm going to take a scaphoid out, a screw out, and fix it with the help of any other device, it has to be made clear to the patient preoperatively that I might be using a plate. So that preoperative planning is done before surgery. So we sort of go in with preconceived notions that, look, it's likely that when I take this screw out, we are going to end up with problems. I might come unstuck and I might have to use a plate. You also make it clear to your patient that, look, I've done lots and lots of screws, but I've only done 10 plates. So you have to tell them that in no uncertain words, that, look, I'm on my learning curve and it may not work, but this, in my opinion, on the day is probably the best thing that I can do for you.
Okay, partly Anil's question is answered, but here ask about the brief about the complications, bailout options if this fails, and plate removal indications.
So very good question again. So if you end up with impingement proximally, you have to take the plate out sooner rather than later, because you're going to take a chunk of the volar part of the radius. So that's dangerous. Bailout options for, I've grown up I'm old enough to be able to use K-wires properly. So if it doesn't work, stick the graft in, put in a couple of K-wires and come out. Cut the wires in so that's always there for you. What was the third question? Was there
plate removal indication? Plate removal indication.
So I've had to take only one plate out where you had volar impingement, and it's likely that this other chap that I've just done, I might have to take his plate out, because if you have only one screw proximally, that one screw is it's just optimistic, isn't it, for to consider that once I get this chap moving, whether or not he's going to do well. But he's one of those chaps who is not usually asymptomatic preoperatively, and that's probably another question which we are going to answer later on, of what to do with the asymptomatic non-union.
Okay. Then again, about plate removal, 2 or 3 questions, similar questions. How often you require plate removal? Does the plate produces the AVN? And what are the chances of impingement? The similar questions are there. So
Sure.
it can be answered in one.
So impingement, we've had 2 cases. One previously where the impingement set seemed to somehow develop over a period of time after union. I can't explain why that happened when we've taken it out. It's likely this other chap had impingement during surgery. but we were able to obviate it by cutting the plate. I haven't seen any cases of AVN occurring. So far, the only reason for removal of plate has been for impingement purposes, but our experience isn't huge. So as a unit, we've probably done only about 15 over the last 3 years. So we are still gathering experience on this. So I wouldn't say I'm not an expert. I
Okay.
tend not to use that word in sentences.
Dr. Bindesh from the Guntur is asking about applying on the tensile surface. How is your experience?
So you mean on the dorsal surface?
Yeah,
I haven't done any.
yeah.
I would strongly recommend.
You already said.
Yeah. So I would say, one of the things about this is Greg Bain's paper is very interesting. If you look at, he's published it in Techniques of Hand Surgery. I might be able to bring it up if it's still up here. It's really worth reading. I think if you can see here, this is his paper, Dorsal Plating of Unstable Scaphoid Fractures by Greg Bain and Joydeep Fadnis. Joydeep worked with us. So please have a look at this paper. I don't know whether I'm clever enough to put this plate over the dorsum of the scaphoid personally. It's hard enough doing it over the volar surface. But he's published this. But again, I don't think we've come up with any significant numbers of cases yet. So till then, I think I would be cautious.
Okay.
I wouldn't start off by plating scaphoids. I think putting screws in is probably a good starting point.
Okay. The question is again two similar questions.
Naveen, Ram wanted to ask something. He's
okay.
Just a question like it's good choice for a non-union with a humpback deformity with bone loss. They had to put a graft and we make reasonable enough to support otherwise. But for fracture, oblique fracture, would you still go for headless screw as your first choice? And then if it's not possible only, you will do this?
Absolutely. I completely agree. I'm better at the screw in those situations. There are some fracture configurations where you might find that the screw is not suitable, but those are far and few in between, Ram. You're absolutely correct. My implant of choice still remains the headless screw.
Second is, what is your post-op regime after this plate fixation?
So we keep them in a cast for a period of 6 weeks, and then we gradually get them moving. I do an X-ray at 6 weeks, the scaphoid views, and usually between 8 to 12 weeks, I get them to move. And like Chaitanya and Joe mentioned, the only way we can be absolutely sure whether union has occurred or not occurred is using a CT scan.
And you could
probably do that at 12 to 14 weeks.
Bone graft, isn't it?
Say again?
When you're planning for vascularized bone graft also, this volar plating could be done.
Yeah. So one of the things we found at Wrightington was that we were not able to replicate the results of all the other units. When we looked at our 70 to 75 vascularized grafts that we did, we were not able to replicate the results of the other units. So, you've got to do something that you are capable of doing. You understand? So I have not done this with a vascularized graft. This is what I'm saying.
Naveen?
Yeah.
Is it okay that we
still plate questions are there?
Can we
two or three questions are there?
Can we take those questions a little later?
Because he's going, probably he has to go. That's why.
Yeah, I think you need to use your discretion and not repeat.
Okay. I'm using my discretion only.
Yes.
Yeah. I skipped many things, but the one suggestion for the impeachment, somebody said, should we apply the plate with the scaphoid inflection to rule out the impeachment?
If you were to apply it in flexion, you would be left with a persistent humpback, isn't it? I don't understand that question, because the whole objective is to straighten the scaphoid out. So if you were to apply it in flexion, or if you were to over contour the plate, you would end up with a situation where you would cause scapholunate instability, in the sense that you would end up with a compensatory DZ.
Okay. Dr. Mihir Kaka from the Mumbai is asking, what is your post-operative protocol after plating? Cast, any immobilization or nothing?
Yeah, I just answered. I told Ram, we just treat it like you would a non-union fix with a headless screw. So between 6 to 8 weeks in cast, and a CT scan at 12 to 14 weeks. We try and get them moving. We don't put them in cast for longer than 8 weeks.
Is there any chances of loosening the screws? Dr. Amit Varade is asking.
So far we haven't. The big advantage of this plate is that they're locking screws, and that might explain why we haven't had any loosening.